Great. All right, I'm going to go ahead and get us started. Good morning, everyone, or good afternoon, depending on where you are joining from. My name is Jessie Mandel, and I'm the National Program Director here at Healthy Schools Campaign. It's so wonderful to see so many people joining this webinar today. Welcome to the second webinar in our three-part School Medicaid Matters webinar series. The purpose of this webinar series is to help broaden and enhance understanding of expanded school Medicaid so that we can leverage the full potential of schools to support student health and wellness and address the youth mental health crisis. While today's webinar builds on material we covered in the first webinar, it is by no means necessary that you join the first webinar for a discussion today. These webinars are designed for you to join at any point, no matter if you're familiar with this topic already or you're just starting to learn more. Now, for those of you who are not familiar with HSC or Healthy Schools Campaign, just a few words about us. We're a national organization working at the intersection of education, health, and equity. We're based in Chicago and draw on our work from Chicago Public Schools. And we're a leader in supporting sufficient and sustainable funding for school health services, including through Medicaid. We are so fortunate and grateful to host this webinar series in partnership with two incredible organizations, Community Catalyst and the Georgetown Center for Children and Families. Before I review today's agenda, I want to mention just a few housekeeping items. First, this webinar is being recorded and the slides will be made available too. We'll send an email with the recording and slides to all registered participants, or you can see the recording, slides, and any resources shared on our webinar homepage, which we're dropping into the chat. Today, we'll have time at the end for a Q&A, but as a reminder, at any time, you can submit your questions to our speakers through the questions box feature, or you can share comments or questions to all webinar participants through the chat feature. We'll do our best to answer all questions, and we'll follow up with you after the webinar to answer your questions. So now I'm going to briefly introduce our amazing speakers and review today's agenda. So very briefly, first, Orla Kennedy, Senior Policy Analyst with Community Catalyst, will kick things off for us today and provide a little context about our webinar series and today's webinar. Then Margot Johnson-Green, State Health Policy Analyst with the Georgetown Center for Children and Families, will give an overview of Medicaid and children's coverage. And Ann Dwyer, Associate Research Professor of the practice, also with the Georgetown Center for Children and Families, will discuss Medicaid's connection to children and youth mental health. We'll then take a deep dive into free care policy, where we'll be joined by Lena O'Rourke on behalf of HSC. Lena has an extensive background in school Medicaid policy and advocacy. And finally, we are so fortunate to be joined by two state experts who will share their insights and expertise around expanding school Medicaid. Kevin Bauer is the Medicaid Policy Specialist for the Michigan School Services Program in the Michigan Department of Health and Human Services. As you'll hear, Dr. Bauer has really spearheaded the direction for school Medicaid policy, and he's a past president of the National Alliance for Medicaid in Education, or NAME. And Christy Gwynn, Deputy Bureau Chief with the Medical Assistance Division in the New Mexico Human Services Department, is also joining us. Christy is the Governmental Affairs Committee Chair for the National Alliance for Medicaid in Education, or NAME, and is leading interagency collaboration and collaboration with school districts for building effective Medicaid programs. So those are our fantastic speakers, and we'll have an audience Q&A after that, and it'll be your time to ask questions and for us to hear from you all. And with that, I will turn things over to Orla Kennedy to kick us off.
Thank you so much, Jessie, and welcome everyone. Really excited to continue the discussion today about using Medicaid to fund school health services. And as Jessie mentioned, this is the second webinar in our series about school Medicaid. Our previous one was about momentum for expanding school Medicaid. And today we're going to be focusing on specifically funding school Medicaid. And then coming up in April, you can mark your calendars for Thursday, April 6th. We're going to be focusing on the organizing behind it and the advocacy space. So we're excited to continue today. Next slide. So a quick recap from the previous webinar. For those who could join, we had a fantastic discussion with former CMS Deputy Administrator Vicki Uccino, and she gave us an overview of this momentum for expanding school Medicaid and what to expect this year. So historically, a little bit of context, Medicaid in the past covering school health services was really kind of under the radar and there were limited opportunities for it. And then in 2014, there was progress with the free care rule reversal. And since then, 18 states have expanded Medicaid's reach beyond children with special needs or children with an individualized education plan to cover all Medicaid enrolled kids, not just those with an IEP. And we're going to hear more about that during today's discussion. And then now, of course, with the COVID pandemic and the youth mental health crisis, there's really a new urgency around increasing access through school-based programs. And we're seeing unprecedented federal attention to school Medicaid. And the group here has sort of called it the school Medicaid trifecta. So we'll go on to the next slide and do a quick overview of that. So this trifecta of federal resources is really coming in terms of new guidance or instructions to states in terms of how to expand and enhance their school-based Medicaid programs, as well as specific financial resources through grant funding, $50 million in planning grants going out to states for building and enhancing their school-based health programs, and a separate technical assistance center to support states on the implementation side. So this is really the momentum that we're going to be seeing and these federal opportunities coming down to states. And so that's sort of what's grounding our discussion today. On to the next slide. And these are a list of some of the helpful resources that we talked about in the first webinar. And as Jesse said, the slides are going to be shared after, so you'll have access to all of these links. But these really are key for good starting points for finding out what your state is currently doing in terms of school Medicaid programming, what the opportunities are for expansion, and then some more information about the context of these federal investments through the Bipartisan Safer Communities Act. On to the next slide. And so really for today, we're going to focus specifically on using Medicaid to fund school health services. And I'm really excited to keep this conversation going. And in particular, to focus on how 18 states are leveraging these federal resources to improve school health services, including increasing the kinds of school health providers that are eligible for Medicaid reimbursement. So we're excited to kick things off. And now I'll turn it over to Margot Johnson-Green from Georgetown Center for Children and Families to get us going. Over to you, Margot.
Thank you so much, Orla, for that introduction. I think we can go on to the next slide. And then one more so we get to the content. Thank you. Before we really dive into most of the content today, I do want to start us off with a bit of positioning as to why it's so important to talk about Medicaid when discussing school-based health and also child health more generally. So in February 2020, a policy known as the continuous coverage provision was put into place in order to prevent Medicaid enrollees from losing coverage during the pandemic. And since 2020, Medicaid enrollment has increased 31% nationally. That means that now over 50% of children are covered by Medicaid and CHIP, and Medicaid and CHIP are the primary coverage source for children in America. And in a recent report that CCF put out, we found that 34.2 million children alone are covered by Medicaid. So we really cannot responsibly talk about student health and child health without having a Medicaid focus. Next slide, please. EPSDT is one of the main reasons why Medicaid is so important for the health of children. And EPSDT is really a hallmark of the Medicaid program for children. So EPSDT stands for Early Periodic Screening, Diagnostic, and Treatment. And it is Medicaid's pediatric benefit. EPSDT ensures that all children and adolescents receive periodic screening to evaluate their development, including physical and mental health, vision, hearing, and dental services. It covers all children under 21 in Medicaid, but I will note that it does not apply to separate CHIP programs. However, because a lot of states do cover it, generally those services are covered even under separate CHIP programs. EPSDT designates that states must provide all covered children with all necessary health services as indicated by screenings. even if it is not included in the Medicaid state plan. And these determinations of medical necessity are made on a case-by-case basis. But the important thing is that states cannot impose hard limits on pediatric services. So for example, if a child gets a pair of glasses, but as children do, they are rough and they play around and it breaks, if an optometrist determines that that child needs a new pair of glasses, then they should be able to get those glasses. These screenings are usually done through a periodicity schedule, and Bright Futures is AAP's periodicity schedule, and it is nationally recognized, but states can set their own schedules after coordinating with child medical organizations in their state. Next slide. So schools really do have a large part to play in this. Schools are an allowed site to provide EPSDT services, and they are an ideal place to do so as it diagnoses and treats kids where they spend a majority of their time, which is in schools. And in August 2022, CMCS Information Bulletin reinforced this, and it provided additional guidance on the types of services covered, types of providers covered, some guidance on reimbursement, and just basically reiterating that schools are an ideal place to administer EPSD services and that states should take advantage of those. Next slide. And before I pass it off to my colleague, Ann Dwyer, I do just want to call to your attention some forthcoming school district data that CCF will be putting out. So on our website soon, we will have data on the share of kids with Medicaid coverage by school district between 2016 and 2020. Using 5-year ACS data. And I'll have folks at HSE put a link to the School Medicaid Matters webpage when it's available on site, so it'll be easy for you all to access. And even more updated 5-year data from the ACS was released in December, so we will also have that up on our website to link to it. One thing to note that when looking at the data is that CCF has rules to maintain reliability of data, integrity of data. So not all school districts may have percentages available when you look at the tables, likely due to the school district being too small to get an accurate representation of, or other general data reliability issues. But the data that will be up on the website will be categorized by elementary, secondary, and unified school districts, because that is how the ACS classifies it as well. So you just want to keep consistency there. And I will note that looking generally at the data, several states have dozens of districts with 50% or more of students covered by Medicaid and CHIP. So the data at school district level really does mimic the general Medicaid trend of over 50% of children being covered by Medicaid or CHIP. So next slide. And now I will pass it off to my colleague, Ann Dwyer, to talk about the connections of Medicaid and mental health in relation to schools.
Great, thanks so much, Margot. And thank you for the overview of Medicaid coverage for kids. So as Jessie mentioned, I'm Ann Dwyer. I'm an associate research professor at the Center for Children and Families at Georgetown McCourt School of Public Policy. So what I will be drilling down into a bit more in detail today is the role that Medicaid plays in coverage of mental health services, in particular for children. So we can go ahead to the next slide. So when we talk about mental health, we really, just like when we talk about kids, we really can't talk about it without talking about Medicaid. So why is this? As Margot mentioned, Medicaid alongside CHIP covers over half of all children in the US, and Medicaid is also the single largest payer of behavioral health care in the US. So again, if you're talking about kids and you're talking about mental health, Medicaid is a big part of the picture. And children covered by Medicaid and CHIP really rely on the programs to support their mental and behavioral health needs. So according to the Centers for Medicare and Medicaid Services, as of 2020, nearly a third of non-institutionalized children ages 3 to 17 who were covered by Medicaid or CHIP had a mental, emotional, developmental, or behavioral problem. So again, that's nearly a third. Yet, as we know, just because a child has a mental or behavioral health need and has coverage, it doesn't always necessarily mean that they have an easy time accessing that care. So while Medicaid provides coverage for a broad and comprehensive array of mental health services, in particular under the EPSDT benefit, this includes therapies, medications, inpatient, outpatient care, and community-based care. CMS has also noted that children who received mental health care in Medicaid or CHIP, about 35% of them had either a somewhat or a very difficult time obtaining that care in 2020. And unfortunately, the pandemic has really exacerbated many of these challenges. So we can head on to the next slide. So the 2022 Casey Kids Count data book really hit the nail on the head when it called the youth mental health crisis a pandemic on top of a pandemic. What we know is a lot of these issues aren't new. So even before the pandemic, we were seeing access issues for mental health care and increasing rates of mental health need across payers and many populations. But a lot of this has been further intensified by the COVID pandemic, especially for children. So as some of you may have seen, in the fall of 2021, national pediatric provider groups, including the American Academy of Pediatrics and the American Academy of Child and Adolescent Psychiatry, came together to declare a national emergency in child and adolescent mental health. And the Surgeon General also issued an advisory on the youth mental health crisis. Since then, we've also seen CMS note that stressors related to the COVID pandemic have resulted in what they have referred to as a surge of behavioral health concerns in children and youth. Next slide, please. So clearly a lot of room for improvement and needed work ahead, but on a positive note, we have seen a renewed focus at the federal level on opportunities to improve access to mental health care, including through school Medicaid. So as we mentioned in our last webinar, and as Orla highlighted in her introduction, the Bipartisan Safer Communities Act passed in June of last year requires the Secretary of HHS to issue guidance to support the delivery of services to children covered by Medicaid and CHIP in school-based settings. It also directed the Secretary to create a technical assistance center focused on school-based Medicaid services, and to issue $50 million in funding for grants to states to implement, enhance, or expand school-based services under Medicaid and CHIP. This past August, the administration also put out two important guidance documents to states on Medicaid and care for children. So as Margot mentioned in her remarks, the first focused specifically on leveraging Medicaid and CHIP to support behavioral health services for children and youth across state Medicaid programs under the EPSDT benefit. This document, this guidance, is really a user guide to states and advocates, laying out existing flexibilities with specific state examples of how states can leverage Medicaid today to support youth mental health. And I'll say notably on the school front, the informational bulletin encourages states to leverage a comprehensive array of Medicaid providers in meeting their EPSDT obligations, including schools, which are called out. And it provides state spotlights on Arizona and Michigan, which, as the guidance notes, have seen substantial increases in the number of students who have received behavioral health services following state efforts to expand behavioral health care in schools. I'll also note on the same day that the EPSDT bulletin was released, CMS also released an informational bulletin focused on Medicaid in schools, where they noted that the role schools can play in providing Medicaid cover services, including, as they note, behavioral health services. So finally, I'll end by highlighting a new resource from the Kaiser Family Foundation, summarizing findings from their Medicaid Behavioral Health Survey of state Medicaid programs, with a focus on leveraging Medicaid for school-based behavioral health services. So while the Kaiser summary notes that state Medicaid programs vary in how they promote access to Medicaid behavioral health services provided in schools, it also finds that over time, Medicaid has played a larger role in supporting school-based behavioral health care. Next slide, please. So with that, we've included a list here of resources on the CCF website to complement what Orla put up as well, including a link to the Medicaid enrollment and school district data that Margot mentioned, which will be available soon. With that, I will now turn it over to Jesse and Lena, who can help us dive more into Medicaid's School Medicaid 101. Thank you.
Thank you, Anne. Yes, thank you so much. I'm excited to take this dive into free care and also to give an overview. So I'm going to kick things off with just sort of an overview of what we're talking about in, around school-based Medicaid. Next slide. So many of you know, for over 30 years, Medicaid has played a role in paying for physical and behavioral health services in schools. And almost all states have their own unique school-based Medicaid program. But across the programs in general, Medicaid pays for the eligible school health services included in students' individualized education programs, or IEPs, or individualized family service plan, IFSPs. And while Medicaid spending on school-based health services represents a small amount, less than 1% of total Medicaid spending, it's a significant source of funding for schools, representing the third largest funding stream for K through 12 public schools. Next slide. Now, taking a step back for just a moment, it's important to note that school health services can be provided by a variety of health professionals through different delivery models. And you all might recognize this slide from our last webinar, but it's important in this context to stress that schools may provide different models for care. Schools may collaborate with communities, partners, or through mobile units, your mobile vans. Schools may operate school-based health centers. And finally, schools or school districts hire staff directly. And that's where our focus will be today, this school employed providers category. Again, to be clear, all models of delivering or financing services are so important in schools. But in the context of school Medicaid or free care policy, we're focusing on providers who are employed by or contracted by the school district. Next slide. So we've covered this game-changing federal momentum that we're in, as Orla and Ann both discussed, and just the role of school health services being elevated over the last few years. So I won't spend much time on this slide, but it's important to just remember what a moment we are in. We've seen historic one-time investments in K through 12 funding. Just last month in the State of the Union, the president called for more mental health services in schools. Our federal agencies promised to jointly address the issue. And then, of course, the real game changer, which was the bipartisan Safer Communities Act, especially a game changer for school Medicaid. As Ann mentioned, it led to the informational bulletin that was released in August and the trifecta of forthcoming changes that Orla lifted up. But really, the Bipartisan Safer Communities Act represents an important recognition of school Medicaid's role in helping states strengthen and sustain mental health services. Next slide. So you've heard about what Medicaid is for kids and the role it plays in supporting school health services and the recent federal momentum. So we'll now be turning to talk about the exciting activity that is happening across the country around school Medicaid and what states are doing right now to expand their school-based Medicaid programs. But here's the big picture. States now have the option to cover all Medicaid enrolled students in schools. Medicaid will pay for services if students are enrolled in Medicaid. Services are covered by the state, the provider is recognized by Medicaid, and all the payment systems and mechanisms are in place. And that's the opportunity that lays before us. And I will now turn it over to Lena, who will walk through more of the details.
Jessie, thank you so much. And next slide, please. So I am really excited to talk to you all about what this opportunity is. We've heard a lot about the environment and the importance of Medicaid in schools and really how all of these pieces are working together. And I think the first half of this webinar really doubled down on why school Medicaid is a successful strategy. And we see that time and time again in terms of expanding federal funding into schools to support student health and the role that state policy plays in this work. And what I'm going to do is talk through very specifically what the opportunity is. And then I'm going to turn it to my colleagues in the state to explain how they've implemented it. So next slide, please. As Jessie said, Medicaid's coverage of services in the IEPs has been critically important for 30 years and has been a really big part of how school-based services have been funded. But Medicaid really only paid for the services that were provided to a limited number of students, those with IEPs. Then in 2014, CMS made a policy clarification that removed those barriers for school-based Medicaid and really clarified that now schools can be reimbursed for all students, regardless if they have an IEP. And this is known as, it's not a real catchy name, but the free care policy reversal. And so we talk about this as expanding school Medicaid or expanding through free care. Next slide, please. So now the impact of this policy clarification, this free care policy, is that Medicaid is no longer limited to students with an IEP, and Medicaid can pay for services to all Medicaid enrolled students. States, though, must decide if they're going to expand or not. And different stakeholders are likely to be involved in that choice. And we're so happy at the wide range of participants on this webinar because you all represent different sectors and different perspectives. But the state Medicaid department, the state education department, the state legislature, the governor, advocates, all will be part of a process of deciding what the state environment looks like and if a state makes this choice or not. Once a state has decided if it is going to expand, it needs to look at their existing state plan and figure out how they will do this. Some states will need to formally submit a state plan amendment or a SPA, and others are able to do this through their state legislative process or through their state administrative process. Next slide, please. If they take advantage of free care, we have seen in states, and again, you'll hear these examples in just a minute, we have seen increased funding for school health services. More services can be covered. We've expanded the provider workspace, the provider workforce, bringing more provider types into reimbursable services. And more than that, this opportunity really allows states and to think about holistically meeting student health needs, behavioral and physical health needs, and allowing the program to follow those state decisions on what that student needs. Next slide, please. And 18 states that we know of have taken advantage of this free care policy and really transformed how they're thinking about the school Medicaid program. A lot more states are in the process of considering it. So the next slide, please. If you're wondering where your state is on this continuum, take a look at this map. The ones in the dark green are the 18 states that have expanded. And the lighter green are in process. And then we also know a number of states are currently considering how they would expand, looking at state legislative in the governor's budget and through other ways all across the country. No matter where you are, I bet someone in your state is thinking about this somewhere on that continuum. Next slide, please. So in addition to expanding outside of the IEP, I do want to say that states have options when thinking about school Medicaid. That is also looking at the benefits that are covered and the providers who are covered. So not just does a student have an IEP or not, but what benefits are covered in the school and then what providers can deliver the services. And I just want to talk about that for a second, because again, that ties us back to the holistic model of care and really thinking about how to transform student health. Next slide, please. So states can reimburse for a wide range of services. They can cover physical health services and mental and behavioral health services. One way to do that in a school setting is to cover all medically necessary services in schools, so that any service that is deemed medically necessary to a Medicaid enrolled student could be covered. And I think that is the most comprehensive way to cover services in schools and the most holistic. So we say that that is the best practice when looking at this. Next slide, please. The other piece here is really thinking about the which providers can be covered in schools, because sometimes there are healthcare providers or behavioral health specialists operating in schools who are licensed under the Department of Education, but may not be a provider under Medicaid. And when that misalignment happens, that is a source of disconnect where otherwise eligible services would be delivered to a Medicaid enrolled kid, but they aren't able to draw down because that provider type is not eligible under Medicaid. Aligning those two sectors of providers helps streamline Medicaid reimbursement and importantly brings in really needed funds into the school system. Next slide, please. I'm going to just put these up for a hot second and move quickly through, but they will be in the slide deck so you can look at them later. I think it's important just to acknowledge the wide range of types of services that are delivered in schools and could be Medicaid reimbursable. So this shows you the types of services that for physical health services that are delivered in schools. And next slide, please. This slide goes through examples of eligible mental health services and the mental health providers. So as you are thinking and asking questions after this webinar about who is reimbursed in your state, the questions really become, for which students can Medicaid reimburse? For which physical and behavioral health services can Medicaid reimburse? For which physical and behavioral health providers can services be reimbursed? And how can we expand that to really bring in as much federal reimbursement as possible? So now I'm going to tip it over to Kevin Bauer in Michigan to talk about what he did, followed by Christy in New Mexico. So you can hear how states made some of these choices and what that looked like. Kevin, let me turn it to you.
Thanks, Lena. First of all, in Michigan, when we expanded our program, the first thing we did was we didn't look at we're going to expand, a certain set of services. We were going to expand all services with the understanding that we would probably see very little to no increase in the number of OT, PT services that we were seeing. We might see a small increase in the number of speech language services and a moderate increase in nursing, which was helpful because Michigan, depending on the study that you looked at, we were 49th or 50th in the nation in the number of nurses in our schools. But we expected to see a major increase in the number of behavioral health professionals that we had in the schools. And in the first 18 months, we did increase our nurses in the schools by 27%, and our number of behavioral health individuals in the schools by 89% in the first 18 months, which was significant. Now, I'm not going to tell you that, we magically had a bunch of behavioral health specialists here that we were able to employ. Some of that was hiring people that were from surrounding areas. Some of it was actually pirating them from a community mental health here and there because they came over to the school side of things. So there hasn't been a lack of challenges in doing this, but we do have, like the rest of the nation, a shortage. So we are currently pursuing other ways that we can bring mental health individuals on board. One of the big reasons for our increase, though, is because we have been well supported by our legislature. And when the program first started, they came out with $31 million in appropriation to bring new providers into the school. That was in 2019's budget. And I'm happy to say that in our current budget, that is up to $680 million in support of the schools. A lot of that, more than half of it, is for the hardening of the schools, resource officers, things like that. However, about I would say 150 million that is one time for behavioral health services in the school, with $56 million in ongoing budget for the hiring of mental health individuals. So that is huge in being able to boost our program and get it kickstarted. We were able to add a number of providers thinking outside of the box a little bit. We went with marriage and family therapist and things like that because their credentials mirror that of a licensed master social worker. And one thing that we were able to do is we were able to add the Department of Ed credentialed psychologist. And I know there's probably going to be a lot of questions on how we did that, but what you're going to hear between states that have managed to do that is the journey of each state has been vastly different than the next state as CMS. Each region has their way of doing it, and how we were able to provide it at those providers was through declaring them to be rehabilitative or habilitative in nature under EPSDT. However, if you talk to states like Colorado, that didn't fly in their state and they had to go a much different route. So like I said, your experience depends. It's usually state by state when it comes to adding those. So a lot of support here in Michigan that has allowed this program to grow, I would say, almost exponentially. So. And we look forward to continuing to grow. Currently, we are working with quite a few states that I see were white on the map. Most recent one we had reach out to us was South Dakota, or North Dakota. So we are seeing a lot of other states getting ready to jump into the expansion of free care, which is very encouraging. So at this point, I can either answer questions or I'm going to go ahead and kick it over to Christy. Which would you prefer me to do?
You can kick it over to Christy, and then we'll have an audience Q&A. Thanks.
Okay. Over to Christy Gwynn from New Mexico.
Thank you, Kevin. And I did have a couple of slides, if we could pull those up. Then we'll talk about what we've been doing here in New Mexico. So next slide, please. But there is my contact information for anybody who's interested. So New Mexico was not an early implementer of the free care expansion. As you all have seen, it started in 2014. And we chose to sit back and wait and see what was going on and what other states were doing. In the midst of the pandemic, our education department came to us after having some conversations internally, as well as conversations with the Office of the Governor, came to us in late 2020 to start these discussions around the collaboration to expand to the non-IEP services. And during those discussions, HSD, my agency, was directed to begin pursuing the expansion. So our first step was to join the Healthy Students Promising Futures Learning Collaborative. So we in New Mexico have a great relationship with our school districts in that we meet regularly with them on a quarterly basis with all of what are known as the Medicaid coordinators. So those people who are actually involved in the implementation of the IEP-based billing and doing the daily work at our LEAs. And so we went to that group and said, hey, we need to get some people together. We need to gather a team to start participating in this collaborative. We're going to move forward with this free care expansion, and had a wonderful group of volunteers, join us in this effort where we really started talking about the types of services we thought we were going to be expanding to, what this was going to look like for our schools, how it could actually be implemented from them, involved our billing agents. What does this look like from the perspective of, streamlining the process as much as we can so that it's as simple as possible for the actual providers at the LEAs. So involving the billing agents and having those discussions around how could the existing systems be utilized and potentially, updated to include the free care services. At the same time, our state agency, the state Medicaid agency where I work, started the work on our state plan amendment, which was submitted almost a year ago to CMS. We also rewrote our administrative claiming implementation plan. So both of those submitted just within days of each other in March of 2022. We also had to make revisions to our state rule that covers our school-based services program. And so because the SPA and the implementation plan were submitted with July 1, 22 effective dates, we rewrote the rule and went through that process to also be effective July 1, 22. And then we knew that there were going to be changes to the random moment time study, as well as our cost settlement report that are going to be needed for FY23. So working with our vendor to make those changes that mirrored all of the changes that had been listed in both the SPA and the implementation plan. So we kicked off July 1, 2022 with changes to the time study, including some additional participants that could be included. a new code to capture the free care services, and then started thinking about what that's going to mean for our cost settlement template that will be utilized when our FY23 reports are completed. So a lot of work, as has already been alluded to, needs to go on between the state agencies. You have to get buy-in from everybody to support this program, ensuring our schools were really well informed of what these changes were going to be, and that also that they were on board, that this is something they thought they were going to participate in, because it's a significant, amount of time that the state agencies are spending on all of these activities, to get everything ramped up and get in place. So that's kind of what we've been doing over the last 2 years. I think the next thing I want to say, and we can move to the next slide, please, is that we found ourselves in New Mexico, and I know we're not the only state going through this, but we found ourselves in a really interesting position in terms of the timing for our negotiations with our friends at CMS. So we've talked about knowing this new guidance is coming from CMS, and that they're working on modifying, changes to the existing policy. And so our submission kind of, I think, coincided with those discussions that were happening at CMS around the types of changes that they're going to make, particularly to the administrative claiming guide. And so we got through part of our implementation plan, was submitted, it was up under review at CMS, and we weren't hearing anything from them. And then they finally came back with the potential for us to have to make changes to our notification and response windows to 0 notification and a 2-day response window. Our current process and the previously approved plan from 2016 included both 3-day notification and 3-day response windows. And so this was something that I pushed back to CMS and said, wait a minute, this has not become official guidance yet. This is not official policy. How is this appropriate for us to be forced to implement at this time? And so we've had some very interesting conversations, I will say, with CMS. A lot of communication has gone on between our agency and individuals at CMS, all the way up to CMCS Director Dan Tsai, including letters that have been sent, detailing why, one, we need to stay at least 3 and 3 for now, and then 2, that we'd be willing to come into compliance with new guidance once that new guidance is official and has been released. And then all of the states we know are going to have time to bring their state plans into alignment with that new guidance. So I think I would say one thing for states that are considering expansion is the timing of this new guidance that we are anticipating coming out later this year. So if all states are going to have to bring their implementation plans and their time studies into compliance with potential changes that are in this guidance, I think that I would consider that as an opportunity to think about, well, we're already going to have to do this guide revision. Why not throw in the free care at this time? Because then that eliminates you having to go back later on and do another negotiation with CMS just for free care activities. It's our understanding that there is one individual at CMS that reviews all of the implementation plans, and that's not just for school-based services, that includes other state agencies. And the timing for that is, can be very delayed. And I cannot imagine what they're going to do at this point in terms of having all states come into compliance with new guidance. So I think that that's something, if I was a new state thinking about this, that I'd really consider is how do I coincide the timing of this with other things that are going to have to be done and changes that are potentially going to have to be made and reviewed by CMS. Next slide, please. So I know, Lena, this is one of the questions that we wanted to talk about, and we're happy to address this further too, but I think the question is, was this worth it? And so I'll say we had a really positive response from our school districts from all of the trainings we did this fall, where we really dug into the details with them of how this was going to work, what additional services we're talking about, particularly behavioral health and nursing. We've provided a lot of templates for them, a lot of guidance documents, and so all of the response from our districts has been really positive. Because our SPA is still pending approval, we have not had any interim claims submitted for free care services yet. So I don't really have data yet on what the volume of services is that is out there that's being provided or potentially going to be billed. So we won't see the full impact until our FY23 cost reports are completed. Our administrative claims look to have increased some, but we know we're also dealing with just overall increases in costs. And we're only 2 quarters into the time study at this point, including free care providers. So I think still a little early to tell what the full impact even on our administrative claiming side is. And as Kevin alluded, I think one of the other things that we know, has been an issue is we're struggling with staffing concerns and funding. And so, continuing to advocate from the state agency side, we know our education department is aware and working on their side as well to encourage the state to provide additional funding for these staff positions and specifically for behavioral health. We know we've built the Medicaid infrastructure and the billing systems are set up. The capacity is there to support the billing. But if we don't have providers for the services, they can't be provided. So really doing what we can to still encourage that. A lot of discussions with our schools and the school budget people around what they can do to consider utilizing existing funding sources. If they have existing Medicaid funding, then using that to support additional FTE and really making sure that they understand that Medicaid reimbursement is not a 100% reimbursement of any of the services that are provided. So there is always going to need to be that level of funding that is supported, outside of what the providers are able to bill and bring in for reimbursement. So, I'm excited for what the rest of this school year is going to bring and what our cost reports are going to look like for the coming year to really be able to see if we can determine how sizable the impact was. We know it's going to be a positive impact because those are services that previously weren't being billed, but to what degree, is still yet to be seen, I think. And we're hopeful based on our conversations with CMS that we should be receiving approvals very soon on both the SPA and the implementation plan. So, definitely, as we've talked about, a lot of things to consider and a lot of things for people at all levels to be thinking about what their piece in this puzzle is and how, states ensure that they move this forward, in the best way possible. So with that, I believe it's time for Q&A.
Fantastic. Thank you so much, Christy. That was really great to hear. And thank you to you as well, Kevin, for going through the Michigan detail. I think so to kick us off with our Q&A here, Christy, I think I'll turn back to you just to carry through that on the note of, is it worth it? You very clearly made the case, yes, even it's a lot of work, lots to coordinate, lots of steps to go through, but your experiences, it's definitely worth it. Could you give folks some advice on what's the first thing that they should do after this webinar ends? What's the first thing that they should do in terms of that first step to expand or improve school Medicaid services in their state?
So I think if we're talking about this from the perspective, if you're an LEA, you should be reaching out to your state agencies, your state Medicaid agency, the state education agency. That's where the work has to come from, right? The state Medicaid agency is the one who holds the state plan and the implementation plan. So they're the ones that have to do the work to negotiate those documents with CMS. So it's reaching out to those state agencies to see where they're at in the process. Maybe in some cases, I think, states may be thinking about this, but they're not sure if the LEAs are really on board with this. This is something it's going to be a collaborative effort for sure. So I would say it's reaching out to your state agencies to see where they're at with the process, in indicating that you're on board with this, that this is something, LEAs want the state to pursue. My LEAs were on us since 2014. And we continued to put them off until the state felt they were in the position to do so. But it really is making sure that those state agencies are ready to do this and in the place to move forward, I think.
Thank you. And Lena, did you want to add something?
I do, because I think Christy's answer is spot on for the LEAs, and I really do want to double down on that. But I also know we have on the call today a wide range of folks, including advocates, and thinking about what everyone in the system could do. I would really think about educating yourself on what the school Medicaid ecosystem is in your state already. We have lots of resources between our three organizations and between all of the people, the whole family who does this work. There are resources available to help you better understand what's going on in your state. A lot of the questions we have are about state specific, and the answers matter so much about what state you're in. So getting the background about what your state covers, who they cover, what providers there are, that will help you understand what the next steps might be. And maybe that's a plug for our next webinar too, Jesse, that our next one is about advocacy steps, and thinking that question through a little bit more. But I think becoming conversant in what is covered now is a big part of what that next step should be.
Great, thank you, Lena. Or Kevin, did you want to add something?
Yeah, what I was going to just add is, to the is it worth it question. And Michigan rolled out their program very fast. From the time that we submitted our state plan to the time we went active was 10 months. So really, that was so aggressive that when we actually implemented the program, I will say that we weren't completely ready. So it was a slow buildup from that time. Currently, we're 2 years into our expansion, so we've settled 2 years already. And right now we're at about $25 million increase in reimbursed funds because of that. Much of that is actually on the special ed side of things because we've added providers and things like that, but we're coming out at about $5 to $6 million with C4S revenue. Now, one thing that I will say is if you are in a cost-based state, that you may see some things that you didn't expect. Like, for example, when we added our school psychs, much of what the school psychs do shows up poorly on the random moment time study. So that has caused a little bit of a drop in our percentages on our RMTS, about 10%. However, the revenue from having those school psychs increased our revenue, even though that our RMTS dropped. So that's one thing that I would caution you to take a look at, and look at the overall net, and not necessarily that one component's going down, but what is the other component doing at the same time. So the overall net was worth it, very much worth it. And besides the financial impact, I don't think you can put a price tag on the fact that we went from servicing 108,000 special ed students to 980,000 students overall overnight. That alone is huge, and that's something you really can't put a price tag on.
Absolutely, Kevin. Thank you so much for adding that. And so as a follow-up question, what is the best resource for states to turn to in terms of looking at how these new federal regulations compare to the requirements, and then how that lines up with what other state plans are doing? So as folks are taking these first steps to educate themselves on the Medicaid program in their state, and amend their state plan, what are the best resources for cross-referencing the plan requirements compared to the federal guidance that's coming out and then other state plans? And maybe that's a question back to you, Lena, or if other folks want to weigh in.
I will start, but Kevin and Christy, I think as the state policymakers, I'd really value what you think of as the best pieces of information. So from my perspective, between Healthy Schools campaigns, resources, names resources, some of the background documents and data sources that we heard from Margot and Anne earlier, all of those are good places to start and to get your feet under you. And I'll drop in the chat in just a second our free care tracker, which has a lot of the underlying documents. But Kevin and Christy, what sources do you rely on in order to cross-reference, or would you recommend to people?
Well, one thing that I would say, it's important for your state Medicaid folks to go through their current state plan and see where there's places that would bar free care from being used. For example, we had a place in ours where you said you couldn't do anything with 504 plans or anything like that. We had to get rid of that. And the big thing is to go through and make sure that you don't have something in your state plan that's going to limit services that are being provided to the students. And once you do that, then it's a matter of deciding what services you can add and how you can add them. And that's really the first things I would think that from a state policy side of things that you want to do.
Yeah, I agree. And I think for us too, so for example, in New Mexico, we didn't have to take legislative action because the code where everything was at is controlled by the Medicaid. The state agencies are the ones that amend that code. So we didn't have to go through our legislature, but that was the second place that we had to look for what is in that code. Again, just like what's in the state plan, what changes do we have to make there? So those two documents are in alignment. Lena's right. The Healthy Students, campaign and all of the information that they've gathered, because the other thing is you don't want to start from scratch. And if somebody else is already doing this work, why would you recreate the wheel? What can you take from these lessons learned from other states? And I think, Kevin and I are both examples of that, where state agencies are willing to help each other out. So even outside of being a part of the actual learning collaborative, you reach out to another state agency, most of the times they're like, they're willing to help you and share with you what they have, what they've done, what their experiences has been. So, I would say too, it's not being afraid to reach out to people and ask questions, because this really is a group where, the end goal is providing services to students and getting reimbursement back to schools. And so everyone is really willing to help out and do that. And as you mentioned too, the National Alliance for Medicaid and Education, which Kevin and I are both a part of, also, lots of valuable resources on our website as well for those types of things.
Fantastic. Thank you. Jesse, I'm going to turn it back to you to wrap us up.
Thanks, Orla. And I do just want to reiterate, there's a lot of questions that are coming in through the chat that we will be following up after this webinar. Keep them coming. They're great. And we will follow up individually with people after the webinar and get back to you. So thank you for sending all those great resources. And I'm going to just mention a few more resources really quickly as we're closing out. And thanks for pulling up the slides. Thank you all for that fantastic discussion. But next slide, we'll just be quickly touching on a few more resources. So this I dropped into the chat. It's a great overview to understand where things are at in your state and get started. So we encourage you to check out this resource as well. It's a great starting point no matter where your state is at in this discussion. Next slide. So in addition to the Healthy Students Promising Futures map, which I just pulled up and shared with you all, there are a few other resources that we're going to be sharing after the presentation, after the webinar today. We'll be putting these on our webinar series website and linking to them after the presentation as well. We'll send an email out to all participants. So there's the interactive map. Hot off the press is a new unwinding public health emergency unwinding toolkit specifically for schools and school districts. So we're really excited about that. And so please take advantage of looking at that resource. And then in addition, there's a new advocacy toolkit on leveraging federal resources. And we'll be hearing more about that, as Orla mentioned and Lena mentioned, in our next webinar on April 6th when we talk about organizing for school Medicaid. Next slide. So please join us on April 6th. It's the final in our series. We'll hear more about getting involved and organizing in your state as we started to talk about today. And we're really excited for a great discussion around advocacy in states around school Medicaid. So please be sure to spread the word and encourage your colleagues and partners to join us on April 6th. Next slide, final slide. And with that, I just want to express my gratitude for you all for being here, so that we can continue to improve equity and access and investments for student health and wellness. Many thanks to Georgetown Center for Children and Families and Community Catalyst for partnering with us on this webinar series. And thank you so much to Kevin Bauer and Christy Gwynn. Thank you both so much for sharing your insights and perspectives with us today. Hope to see you all again on April 6th and have a wonderful rest of your day. Thanks again.